So I just want to welcome everybody back. I hope you've all had a chance to stretch your legs. I know it can be a long time on a virtual meeting, but it's been really fascinating so far. So I'm really grateful for everyone who's spoken and contributed to the panels. We're going to move on to the last session, which we've entitled Courageous Conversations. We just wanted to really have a bit of time focusing on communication. I think the diagnosis of cancer brings many difficult things, but one thing can be hard conversations that people never thought they were going to have. And I think just whether it's receiving bad news or starting a conversation with family members or those close to you or with your team, sometimes it's the things that we don't say that can be the most difficult. So I'm very grateful for our panel who have put themselves forward and agreed to speak. And I'm going to let them all introduce themselves and tell us a little bit about the work that they have done or are doing. And so first of all, I'd like to introduce Ransi Chidabi, sorry, hope I said that right, who is the Executive Director of Project Pink and has received one of the IGCAN awards for their project Pain and Palliative Care project, and he's going to tell us a bit more about that. So thank you very much, Francie.
Okay, thank you so much for this amazing opportunity to speak to the community about the work that we are doing. Um, title of my presentation is also the title of our project, which is Count Me in Pain and Palliative Care Project. I am Ronsi, Executive Director of Project Pink Blue. Just to disclose sort of my conflict of any conflict of interest. And I know so many of you may know about Project Pink Blue and some may not. So I just want to spend just a few seconds just to tell you that Project Pink Blue is a cancer nonprofit that is based in Nigeria. And we really are changing the way Africans think about cancer with our different programs we're involved in cancer awareness, fundraising, palliative care, oncology education, psychological support, patient navigation. We really have been in the forefront of advocacy in Nigeria using the press and using different strategies. And these are pictures from our different training. We've also really integrated a lot of research in the work that we do in Nigeria. Yeah, so I would start this presentation by just starting with giving you an understanding of the cancer healthcare health system in Nigeria. Nigeria, of course, is the largest Black country in the world with a population of over 330 million people. Every year, we have about 120,000 cancer diagnoses. And we have just only 80 oncologists in the entire country. We have only 16 radiotherapy machines. The country requires about 308 million US dollars for cancer control over the next 5 years. And then the state of gynecologic oncology, gynecologic cancers in Nigeria, cervical cancer, we usually have about 13,000 cervical cancer diagnoses. Painfully, about 7,000 people usually die, which is about 51%. For ovarian cancer, over 2,000 people, about 1,800. You would actually see from the statistics here that both for ovarian cancer, for vulvar cancer, and for vaginal cancer, over 50% of all these diagnoses of these women really die of these cancers. The painful thing is that most of these patients, most of these women who die of this cancer all die in pain. So the core focus is, yeah, why would women have to die in pain? Why would patients really have to suffer so much? Uh, you know, if they have probably end stage that nothing could be done, but why can't their pain to be mitigated? Unfortunately, about 98% of women present with advanced gynecologic cancers in Nigeria, and access to those pain and palliative care, it's really not accessible, not available, not also affordable for the women and their caregivers. Pain, it's technically to some extent like not really a priority in Nigeria. And so our pain and palliative program really focused on making this a priority in Nigeria. And we use three approaches. Thanks to the IGCS for the grant, which has helped us to implement this project. And the first strategy was advocacy. Second one was training. And the third one was a pilot intervention. And what we did is that the Count Me In, we wanted this project to be a patient-centered and a patient-driven project where we want the women living with cancer to be the voices that will advocate and push for pain and palliative care, priority in Nigeria. So we started first by setting up a steering committee from people from all over the world. We have people from Harvard, we have from our community, we have IV patients, we have Anissa, we have Director General of NICRAT. He's so passionate about this project. We have religious leaders, both the Christian and the Muslim people. We have them on our board. We have pharmacists. So just a diverse, individuals to help us shape this project. Afterward, we started what we call the co-creation. We had a co-creation meeting where we do not want to package this project and bring to the patient. We want the patient to really drive and co-create it and co-design how best this project should be. And we really engage about 11 women living with gynecologic cancer and brought them together in our office to have the co-creation. The co-creation provided an opportunity to share their stories. It provided opportunity to connect with each other. It provided an opportunity to play games. We have really discovered that in most cancer conversations, it's always so serious. People don't have fun. So we just decided to have fun, to drink some juice and play around in our office, which is what we do in our office many times. And then we laughed with each other. We crack, joke, and make every patient feel homely and all know they're all welcomed. And then from there, through this process, we're able to get out some very important, information on how best to drive this program. Some of the messages we see from our patient was one that said, when I was diagnosed with cervical cancer, I experienced abdominal pain. I've experienced period cramps, childbirth, but the pains are much more. The pain comes like it's eating you, like something is eating your skin inside. Without a painkiller, it will not subside. We've seen our patient talk about even the kind of pain they've had really make them to chase their children away, to look for someone to care for their children because they get so aggressive because of the pain, and they feel it's best to really have other people care for their children. From the co-creation, we started what we call the Diocese Scroggios Patient Advocacy Fellowship. And we have most of the fellows in the room here. And, they've been introducing themselves in the chat box. So feel free to connect with any of the patients if you want. Yeah. And the whole idea for the Diocese Scroggios Patient Advocacy Fellow is to groom more Diocese Scroggios. We know Diocese Scroggios really love Africa. She wanted the best for Africa. She wanted the best for Black patients. But we wanted to groom a community that can speak for themselves and the community with the spirit of Diocese Scroggios. So if you see anyone anywhere say, I am Diocese Scroggios Patient Advocacy Fellow, just know that they are carrying the spirit of Diocese Scroggios. And then this is what happened in the training. We hosted a 2-day training for the patient to share the story of Diocese Scroggios. And we also have the grandson of Diocese Scroggios join us through Zoom and have a conversation with her all the way from US. And then we actually present certificates to all the champions. You can see all their pictures looking so beautiful with the uniform, all of them. And we also had, we're so happy that the message about pain and palliative care was all over national newspapers, on Daily Access, on This Day Nigeria, on the news, on Nigerian Guardian, and so many other newspapers. And the second part of the project now is that we are hoping to pilot the pain and palliative care units to show in Nigeria that having a unit providing pain and palliative care is possible. And this is what the center is going to look like. This is what we have in the video is more like what it was before. And then what it's going to look like is what you're seeing over here, we're going to redesign it and make this to show that this is possible and encourage other people across the country to pilot that. Ending this presentation with special thanks to Ivy. She's a cervical cancer patient who was our co-chair. Unfortunately, we just lost her on the 5th of September. And it's because of people like her we continue to fight, we continue to advocate that pain should be addressed. No patient should ever really, really live with pain. Thank you so much, and I look forward to questions.
Thank you so much, Ronsi. I think it's incredibly moving and, as you say, just so important. And I think, sadly, we know we can't cure cancers, but we can care for people and people can live. And it's so nice to see people laughing and enjoying things. And that's just really vital that we make sure that that can happen. So thank you. We'll look forward to some more questions. I think there was one just about someone's curious about the incidence of womb cancer because it wasn't on your slides, but in Nigeria. So we can maybe come back to that. But I'm going to carry on with the rest of the panel introductions. And next is Karen Nakawala, who is another of our EDI grant holders. And she is, I'm going to get my right slides here, going to give us a presentation on her project, but also tell us a bit about herself. It's Beyond the Surface, Recovering Me and My Sex, so supporting sexuality and self-esteem in women post-cervical cancer treatment, and that's in Zambia. And she's the foundation of the Teal Sisters Foundation in Zambia as well. So welcome, Karen.
So thank you so very much for this opportunity, and I'm really grateful. I think joining this community has taught me quite a lot, especially when it comes to engaging people with lived experience. And this project, for me, especially is really close to my heart because it's actually based on my personal experience with cervical cancer treatment. So I thought. At first, I thought maybe what I was feeling was unique to myself, but after talking to my fellow survivors, I realized that sexuality is actually, I think, one of the biggest side effects that we go through as survivors of gynecological cancer treatment. And so, thank you so much for supporting this project because it has enlightened not only myself, but the women that I work with as well. So it is called Beyond the Surface, Recovering Me and My Sex, Supporting Sexuality and Self-Esteem in Women Post-Gynecological Cancer Treatment. So Two Sisters, I started Two Sisters because when I was going through treatment, I didn't have anyone that I could lean on, for support, anyone who knew the journey. And so after I finished treatment, I realized that there was a gap and I needed to be that person that I needed at the time that I needed her. So I chose to be that person. And then through that, I have brought on other survivors that have become, bloody sisters. So we literally are patient navigating fellow survivors through the system. We get together once in a while to just, talk about what we're going through. And through this project, we've actually managed to support the Zambia Cancer Survivors Support Network. So it's more than just us talking about our sexuality, but looking at survivorship holistically, the things that we have to go through on a daily basis. So through the treatment, I didn't have to go through the side effects in detail, but one of the things that we go through are menopause, which is radically induced, vaginal atrophy and stenosis, which has become a real problem amongst the survivors. They have pain during intimacy, discomfort during medical exams. And because of that, many women are losing their marriages because of the atrophy and the stenosis. The men are thinking there's something wrong with them and they leave them and get other women, marry other women. And you can imagine what this does to somebody's self-esteem. And there's also the loss of libido and sexual dysfunction, urinary and bowel changes. infertility and hormonal imbalance. I think infertility, especially for those that have never had children, is actually a very big issue, and so we're trying to seek help for them, getting somebody to speak to them. It's we don't have the expert help, but I think we're trying as a community to see how best we can cushion the impact. And we're hoping that the near future we're going to have the help that we desire. So survivorship beyond the clinic, what happens after treatment ends? I remember when I finished my treatment, which is now 6 years ago this month, I felt lost. I was so used to going to the hospital for my checkups. I would call my doctor anytime I was feeling, not feeling okay. But after that, I felt like, into the 5-year mark, I felt like I had thrown the roots and there's nobody to help me. And I've got these side effects that, that I face every single day. I don't have anyone to help me professionally with them. And then we also get the stigma that persists long to the physical recovery. And because of that, you find that many survivors are facing isolation, depression, and low self-esteem. I spoke about loss of relationships, and some of them even lose their income because of the length that the treatment takes. And so when we got this grant, the first thing I did was I gathered the women together. I've got some group of about 120 women. These were taken off the Facebook page, which has about over 150,000 women. And so I sat with them and I asked each one of them to tell me what they are, what side effects they're going through, especially after the treatment. And so we did the survey. I think one of the things that came about was the lack of support, whether it's at a family level or community level, and the shame that goes with the diagnosis, even after treatment, and they feel alone. Common desires, they don't have peer support, they don't have better information, and there's no counseling. And like I said, from this we formed the support network. Some of the pillars, how beyond the surface supports the survivors. So we create a safe space for sharing lived experiences. And of course, survivor-led discussions on sexuality, body image, and relationships. Having these discussions amongst ourselves, I think this makes you realize that you're not the only person going through certain things. And it's easier to open up to somebody who has walked the journey than to open up to a doctor who may not really know what you're going through. They have an idea, but honestly they don't have a clue what you're going through. So when we talk amongst ourselves, we actually find a lot of comfort. When we do this up, you actually feel better at the end of the day, like somebody has just told you how to navigate whatever it is that you're going through. And sometimes it's just having somebody to listen to you, be able to help, but the way to listen to you, and that just helps. So we look at healing holistically, we look at the emotional, the financial, the spiritual, and now we're seeing this month, I think this year we met, next month we're meeting for the 5th time. And this has really helped us with the project, because everything that we're doing, we're trying to curate IEC materials. Everything is based on what the survivors are telling us. And I think this is where meaningful engagement with people with lived experience comes in. I don't think we want to be passive as survivors. We really just want to be part of whatever process is going on, whether it is research, clinical trials. We just want to be part of that. And so through the breaking sexual health silence, it's in Africa it's taboo talking about sex. I think it's only now that you hear people on radio or television talking about sexuality. I remember the first thing I did when I went back to work, because I work on radio as well, I told my boss I want to talk about cancer, and at first was like, Karen, we can't. Talking about sex and vagina is going to get us into trouble. We'll take all our license. And I said, I'm going to try it. And when I did, we was shocked at the results we got. It was the men asking questions, asking where they can take, where they can go for screening. And ever since it has become easier for us to talk about it, because I keep saying, I try to call the cervix another name. It is a cervix and it is the vagina. So I'm trying to change the language. I think we have to get comfortable with that. Obviously, being culturally sensitive. But at the end of the day, it is what it is. And I think that has really helped us tackling the taboos when it comes to vaginal stenosis and everything that goes with it. The other thing we're trying to look at is having partner counseling, the men as well to attend counseling sessions. But at the moment, we just want to make sure that the women are comfortable talking about their sexuality before we can actually include the men in our discussions. So we're looking at preparing the survivors toolkit, and this is aimed at empowering the next wave of fighters. So like I said, we're developing literature and guides for patients during treatment, and we're looking at mental wellness, intimacy challenges, physical side effects. And of course, we want them to be informed, about their situation, so that I think they're able to manage the expectations when they know what is happening with them. So why is aftercare agent? Survivorship is lifelong. I'm talking about 6 years now, 6 years this month, but I still struggle every single day. There's something that reminds me that I went through that process. And most of the time, it's not a silent reminder, it's a loud reminder. It's painful, So it's long-term mental health care, sexual health education for healthcare providers. We're having another session with them in the coming month as well. And of course, I think funding survival-led programs is going to be very important when we deal with aftercare services for the survivors. And so courageous conversations is that for us, it's about restoring voice, reclaiming power. It is so difficult to talk about something that you're not allowed to talk about. And I think this is where the courageous conversations for me come in. In Africa, like I said, talking about sexuality is a taboo. It's a no. And so it was difficult at first. I really had to gain the trust of the survivors for them to be able to and discuss it with me freely, and other people that are able to, like the doctors and the nurses. But idea is not something that you talk about all the time. And so for us, courageous conversations is about safe spaces for truth, survivors sharing openly about sexuality, identity, and emotional recovery post-treatment, breaking silence and stigma through connection, centering survivor voices. I think for me that is very critical, that we should involve survivors in whatever it is that we're doing. There mustn't be an afterthought or a by the way. We need to involve people with lived experience from the beginning. And I think this project has just really cemented that. And it's good when you listen to their stories and use them as tools for advocacy, and change. And of course, advancing holistic aftercare, reinforcing the project's mission to include emotional and sexual well-being in the recovery. And that is the group of ladies that we are working with, these cervical cancer survivors. We have 2 ovarian cancer survivors. And then we have, some of you may know Professor Paham and a couple of doctors from CDH. And this has been really amazing. And I can't thank you enough for the support. Like I say, it is not just about surviving, but how we survive. I think it is very important to look at that. So thank you so much for the opportunity. Thank you for giving me this privilege to be able to share with you. Thank you.
Thank you, Karen. It's just amazing work that you're doing. And I think, really highlighting that benefit of the peer support and just, as you say, the safe spaces, and letting people start those conversations and not having to hold everything inside. So we'll come back to some of these themes. I'm just going to carry on with introducing the panel because I'm also now delighted to introduce Nisi Maburu, who is a gynecologic oncologist from Kenya. And as we heard from Runsi, also a member of the palliative care, IGCS palliative care program, and has set up the She Fights Cancer Foundation. So Anissa, really looking forward to hearing from you too. Thank you.
Thank you so much for having me. The discussion has been riveting, to say the least. And trying to follow Karen and Ramsey, that's really a tough act to follow. But hey, I'll take on the challenge. So, as you've heard, my name is Anisamburu. I'm a GYN oncologist based out of Kenya. And just a bit about me is that I was an IGCS fellow, currently graduated. And I also am an early career mentor for IGCS, as well as the co-chair of the palliative care work group for IGCS. I am the founder and CEO of the She Fights Cancer Foundation, a non-profit organization that is for women by women that specializes on providing access to surgical care for women's cancers, building surgical skills for our local gynecologists, as well as advocacy and awareness about women's cancers. And so it is important to have just a slight perspective from across the table now, being on the doctor's side looking in. And one thing about working in a setup like I do in a low resource center is that many women come with advanced diseases. And so from the onset, from the day one that we meet, we already start talking about the hard truths. We're talking about confronting mortality. And we all know that how difficult this can be. And Karen has extensively talked about cultural sensitivity is something that we face a lot of. And the women who will refuse treatment completely if it's going to affect their fertility. You cannot even start talking about sexual health because it's against cultural standards. And of course, there's several barriers that we deal with. Having a diagnosis of cancer, it's been said before, has been found to be a death sentence. So even in advanced cases, people will be, in early cases, women will be terrified of even coming to the hospital. And one thing that I face quite a bit in my community is that the woman has no voice. She relies on her husband, on relatives who have to be phoned from wherever they are, have family meetings to be able to discuss what is good for the woman. And there are times when women who, based on how our health insurance system is, they're relying on their husband's health insurance. And once they get the diagnosis, that's it. The husband removes them from the health insurance and they're not able to access any care, even if they want to. And so based on this kind of experiences that we deal with, a few approaches that I have cultivated over time is the fact that from this side, we really need to learn to listen. We need to understand what the patient already knows. We need to know what matters most to her. And sometimes it's subtle. It can be just from a little comment that she makes that I used to sleep very well, but now I can't sleep. And you find out maybe she's having a lot of pain. Rancy told us about what Miss Ivy talked about, that she had a pain like she'd never felt before. So when we listen, we are able to find out what is most important to our women. And we need to be as clear and as compassionate as possible. I walk into some clinics to support them and I hear some medical jargon and I can see the faces of the women, of the relatives just clouding over because they don't understand what is happening. And again, even us doctors, we feel so uncomfortable talking about topics about fertility, recurrence, because all our medical training is about the disease and the cure. We do not look at the aspect of a woman as a holistic person, as Karen talked about. We need to understand that these are women is talking about the fertility, the recurrence risks, even death, and we should be able to talk about this. At the same time, we need to impose balance. We want to give them hope without taking it away, and at most every woman should be able to maintain her dignity at every point. And the best part is when we're doing this, we never have to be alone. We need to involve our family, the patient's family, their friends, their nurses. I have one of our chemotherapy nurses who's so excellent at talking with patients and encouraging them. And these are the people we need. And one of the most difficult things that I deal with is respecting patients' choices. One of the things is that we know that there are times when women will say, nope, I do not want treatment for whatever reason, and being able to say, I respect your wishes, I will step aside and do what you need, regardless of all the counseling that we've done, that can be difficult sometimes. And so moving forward, it's these kind of conversations that are really important, because it is not just a luxury to be able to have this kind of conversations. It is part of the quality care that we wish to offer. And one thing that we've done with my foundation, as well as the hospital I work with, we involve the healthcare workers. This is a picture of one of our program managers in the East African Cervical Cancer Project, who we rallied to do the World Gynecologic Oncology Awareness. And this lady here is the president of our local gynecology society, because we're trying to get as many obstetricians and gynecologists to also get into the system of understanding these women and referring them early. We are looking also at patients. We're using their voice, something like this meeting. We know that it's better to hear it from the voice of a patient. And this is a photo of me and a two-time cervical cancer patient with whom we collaborate with a lot. And this is us in a gym just last Saturday, where we had a dance festival to raise awareness for women, telling them about how to be fit, emphasizing on fitness and even survivorship after cancer. And so these are the voices that women will listen to. Others, thank you very much, and I hope we can discuss more in the panel.
Thank you, Nisi. I think I can just see all the comments coming through, absolutely echoing everything you've said there and how important it is. And it will be really good to get onto our discussion, but we've got one more fabulous panel member to introduce, and that is Victoria Clare from Overcome in the UK. And she's going to present some of the work that Overcome does, but also hugely grateful because we've got some videos from some people with lived experience as well. So we're going to look at that, and then we'll come back to the discussions.
Thank you, Roz. I mean, first of all, what an amazing panel. Gosh, I'm really hoping that I'm going to be able to pull some of the themes together that we've heard about, and then present a patient perspective at the end of it. So we have 3 patients who have come together to record videos specifically for this session. Just a very brief introduction from me. So I'm Victoria, I'm the CEO of Overcome, and we're the UK-based specialist support and information charity. In some ways, in listening to some of the other kind of differently constituted organisations that have been talked about today, we are a version of that. So we are a version of kind of a community in the UK. We are sort of an NGO, so a registered charity. And we have around 5,500 members across the UK. But you don't have to be a member to access our services. So we supported around 6,500 people last year, and our online forum has 18,500 people in over 120 countries. Plus, our booklets were downloaded last year 65,000 times. So we do a lot of awareness raising and of signs and symptoms, and we are run by people diagnosed or personally affected by the disease. So next slide, please. Thanks, Debbie. So these support groups, all of them have been requested by members or by people using our services. And within these support groups, it's really important to note that these are safe places. So as an organisation, our staff are trained and qualified and able to facilitate these groups. But ultimately, the special thing about this, which is the thing that so many people have spoken to the point today, is that actually these are patients, these are people affected, talking to each other, drawing strength from each other, having courageous conversations with each other, supporting each other after courageous conversations. So whilst we give some structure to that and we sort of hold a safe space, ultimately it is the community that is contributing. And this just gives a sense of some of the sort of the specialist support groups, or, you know, sort of slightly kind of nuanced sort of specific groups wherein people can have those conversations. So next slide, please. So in talking about courageous conversations, I think it is worth saying that we asked our community And when we're talking about courageous conversations, we're actually sometimes talking about difficult conversations. Difficult conversations are hard to have. And these are the ones that are most frequently coming through on our support lines or through in our forum. It's talking to family, point of diagnosis, or with regards to ovarian cancer particularly, diagnosis or recurrence. End of life, palliative care, terminal disease, those sorts of conversations are hard to have. Very often people report to us that stoma and having a stoma or having difficulties with bowel movements or urinating or anything relating to that, anything related to using the toilet can be a really hard conversation to have. And also sex and intimacy. And as has already been spoken to the point, is that actually sometimes within our community or within groups within our community, there are certain groups within which, or there are certain families within which there's additional stigma related to some of these conversations or some of these sort of difficult points. Likewise, I think culturally, it's really important for us to respond in an appropriate way and to respect the way that people would like us to talk about these things, the language that people feel comfortable with us using. I think it's incredibly important. So, Debbie, could we have the next slide, please? But before we start to play Amanda's clip, I just wanted to say, so Amanda's backstory, she's really brave in sharing this, actually, for all of us today. So her backstory is that she was diagnosed with ovarian cancer, but in being diagnosed with ovarian cancer, she had a number of comorbidities that made the treatment very likely. There was a strong chance of adverse events, serious side effects, or her not coming through treatment. So this is Amanda talking about the conversations that she had and how hard they were.
It's never easy. These conversations are not easy. I've had sleepless nights. I've had tears from both me and from my partner, my mum and extended family. Plus the conversations of, are you actually going to go through with this? To you must go through with this, and trying to decide about whether you should go through it or not. Because at the end of the day, it's your pain, your management, your side effects, your life. You have that choice. So these conversations can be really, really hard, and if you ever want to speak to anyone about it, Overcome are absolutely fantastic.
So importantly, the reason why we left in that little bit about her saying that Overcome is fantastic, number one, because we love her for saying that, but number two, I think really importantly, what we have to recognize is these conversations do not happen in isolation. So the difficult conversations may happen with the clinical team. But then there are difficult conversations for those patients to have with their family members. And then there are difficult conversations that they come back to. So there's a continuum, with every piece of news, with every one of these particularly difficult topics, with every one of these problems or these barriers or these things that these people are bumping up against time and time and time again. It's a continuum of difficult conversations or courageous conversations. And really this presentation, Dr. Glasspool asked us to really focus in on kind of how, what do patients think would make it easier? How can we structure our courageous conversations? And I'll come back to that because actually we have some really good feedback. But so the next clip is from Karen, and she is talking about her diagnosis. And in some ways, what made it harder for her, and in some ways, what made it more difficult for her.
Hello, my name is Karen. I'm from Northern Ireland. And I'm 62 and I'm married with 2 grown-up daughters. In September 22, I suddenly became unwell over a period of a few days with pain in my right side. I saw my GP who sent me to A&E in Belfast. I was admitted there and given pain relief and sent for a CT scan. I was then admitted to the ward overnight, and the next morning a consultant came in and asked me, did I want to know the results of my CT scan or did I want to wait for my husband? Well, I kind of knew then it was not going to be anything good. So I asked him to know, and he sat down and he quietly explained that it showed I had advanced ovarian cancer. It was a total shock, as I had been up to this point fitting well. I managed to ask him if I was palliative, and he said I was. He went on to outline where the cancer had spread to in my abdomen. It wasn't good. I remember thanking him, and then I was given time to take the information in by myself. When I look back, I feel this gave me the time to draw up some strength before my husband came. And that was very important to me, as I didn't want to break down in front of him or anyone. The ward sister came and she sat with me, and I was able to talk to her. She was lovely. I just told her a wee bit about myself, and it sort of helped. My husband arrived, and he too was told the news with me. We were in a single room, and we were able to have the time to talk, hold hands, hold one another. We lay up in the bed together. The blinds were quietly drawn, and we were left alone. And I feel this space gave us the time to process this shocking news. We've been together since we were 20, and this was not what we had planned. The next day, Andrew wasn't too good. He'd found going home alone at night very difficult when he went into the house and he was by himself. I think it wasn't good feeling. The staff, on hearing this, allowed my husband to stay overnight on a mattress beside my bed. We were treated with such care, kindness and empathy. I really believe the support we received from all the staff gave us precious time to talk and support one another and set ourselves on the right track for all that was to come. We will always be grateful for that understanding care that we received from the staff of the Ulster Hospital in Belfast. And that is actually 3 years ago this week that I got the news. So I'm doing well. Thank you.
Thanks, Debbie. So the next patient we have is Emma, and she's really in her video, she's really talking about the fact that actually after a difficult conversation, after a courageous conversation, there are things that can make it easier. And so she's really talking about that.
I was very overwhelmed, very upset. Not in a good place, as you might imagine. And my lovely CNS, Helen, was absolutely fantastic. She's always super calm, super empathetic, really, really kind and caring. She'd already made sure that there was a separate room that we could go to after that appointment time with my oncologist. And we sat in there, and she was really understanding. She explained why decisions were made. So her just being there, and that being that space, and a quiet space, and knowing that I'd need some time, and being able to just translate things a little bit, even though my oncologist is lovely. Obviously it was very medical, and at that point in my journey I didn't understand perhaps as much as I do now and have educated myself with now. And she was very caring. It wasn't rushed. The time sort of didn't matter. And she wrote things down so that I could then obviously take them away and have a look at them later. Subsequent to that, she was always on the end of a phone, and I've spoken to her many, many times, and she's always been hugely supportive. But that conversation there where I was very, very overwhelmed and facing a very uncertain prognosis at the age of 48. She felt like a real safe guiding hand.
Thank you, Debbie. Could we have the next slide, please? So we pulled all of this from our various groups, our specific groups where we see more of those courageous conversations happening. So what does good practice look like? This is the patient perspective, and this is really speaking to clinicians, healthcare professionals. But actually also there's a flip side, because patients can feel more empowered when they request this. So what good practice looks like, the patient perspective: presenting information clearly without jargon, calmly, not offering false hope, not forcing acceptance of how the clinician sees the situation on the patient. So checking with the patient what they want to know and what they don't want to know, allowing ample time for questions, really listening to what the person is saying, allowing thinking time, allowing friends and family to participate in that conversation if the patient would like, and choosing a quiet, private space. From a patient perspective, they tell us that self-advocacy looks like this: asking for clarification when you're given jargon or you're given information that you can't understand, asking clearly what the prognosis is, or clearly expressing that they don't want the prognosis. That's how a patient can help themselves feel empowered. They requesting information, saying, can you please slow down a minute? I need some time to take that in. Can we come back? Can I have another appointment? Can I stay in the waiting room? Is there somebody else I can talk to after this? From a patient perspective, if the clinician doesn't really appear to be listening to what you're saying, or appears to be delivering that news in a way that is too fast or really isn't giving space, for a patient to just say, well, stop a minute, please stop, can feel incredibly empowering. It can mean that actually they get to take that information in a way and in a time that is more acceptable for them. And that, we know to be true, helps people make more informed decisions. And asking for thinking time, asking for quiet space, asking for a quiet time, asking to go away, to have a walk, to come back. Those things are all things that patients can do. To give them just a pause, a little bit of a time to have some breath, or a little bit of time to control that conversation a bit more, or to better understand the sort of their options within those difficult conversations. Could I have the next slide, please, Debbie? Thanks. So here's just our contact details. And yeah, Shreya, thank you for that. And I guess really, having listened to everybody else's presentations across all of those really difficult, within the context of courageous conversations and difficult situations, I think we're all really identifying the same things, aren't we? I mean, I guess, there are your themes. And I suppose the question for us is that, in the UK and within Overcome, we're incredibly privileged to have the resource to enable patients the time, the space to think things through, to talk through things with our staff so they can prepare better for those appointments. But I think there are good practice things that we could all do better. And Nissi, I loved your points. Actually, essentially, I don't really think the last two slides of my presentation were needed, actually, because some of the co-presenters on the panel have basically covered those points already. So I'll stop now and hand back to Ros.
Thank you very much. And I'd like to thank all of you for putting all together your presentations in your time today, and also a huge thank you to the patients who did those videos, because I think it's just much more impactful and powerful when we hear from individuals themselves. And I think they highlighted some really important things. When I watched the videos before, I just felt it brought one of the themes that we'd already talked about the holistic care. And I love the fact that I think it was the ward sister who came and just asked a few questions about a patient, because doctors do sometimes focus on the disease and they're worrying about all these different factors of the disease, but it's the person with the disease, not the disease, that defines the person. And as you say, the space and the time are incredibly important, and revisiting things and just giving people the chance. I suppose one of my questions to all of you as a panel, before we come to some of the questions in the chat, was there's an awful lot of things that are left unsaid because we're afraid to ask, both from the doctor's side and from the patient's side, and between families and things. So what do you think's the best way of supporting patients to initiate some of those conversations and to start those, being brave enough or courageous enough to start them? I suppose I'll start with Runcie.
Okay, yeah, thank you so much. Yeah, so the biggest problem we have in our own context is usually sort of clinical workload from the clinician's point of view, and they usually don't have to spend enough time with the patient. What we have done as an organization to really mitigate this is that we started a patient support group, and we bring the doctors, the clinicians to our support group. And once they're out of that hospital, you realize that they have more time and spend quality time in supporting patients. So sometimes the questions that they might not be able or they might not have the time to answer in the clinic, they have more time to answer these in the support group. That has really worked for us so well. And I think it's something that we encourage people to probably replicate. There are no sufficient patient support group, to the best of my knowledge, across Africa. So I think it's really useful to use that. The second thing is we encourage patients to write your questions down. Don't wait till you interface with the doctors. So we piloted a program that we called 5 Questions to Ask Your Doctors. And we piloted with our patients, and we asked them to use that 5-question guide to go along with them during the clinic, and they can use it to ask. And all your questions can be answered by the oncologist. It could be the nurse, it could be any other healthcare worker that could support you. And lastly, we encourage peer navigation, peer mentorship. Don't wait till you ask the doctor. You could also ask other patients, and you could also drop it in the WhatsApp focus group. And it's been very useful to us, and we encourage that a lot.
Karen, how have you found it when you have your peer support groups? To sort of start the conversations off and encourage people even into the group?
So what we've done is we've introduced a patient's journal, like a journal. There's some patients that, even in our group, they're still not free to talk, especially the older ones. So you find that they actually find it difficult to open up because they want to just put you on the side and talk to you. So we've introduced a journal where I encourage them every day to just write how they feel and to even put down a question regarding how they feel. So if I meet them, most of the time I meet them one-on-one, because now my office is at the cancer hospital. So I'm able to go through the journal and I'll be able to pick up the discussion from what they have written. So what we're doing now is we want to introduce this journal with the doctors. When they go to see the doctors, or whether it's the nurses, whoever they're seeing that day, they take the journal with them and they give it to them so they can read. Because again, there are times when the doctor is so intimidating and so the patients are scared to ask the right questions or say how they feel. And sometimes they seem too busy. When you peek outside, you see there's a long list of people waiting. So you find that the doctor won't have a lot of time. But if they have the journal, they're able to read and they're able to pick up. So in this journal, the doctor is actually supposed to even put his comments, after he finishes his session. So if there are things that need to be interpreted, and she can come up to me, or the navigators will go through and explain to her what the doctor said. So this one is one of the ways, and especially given the doctor-patient ratio that we have currently, which is really very high. And yes, we appreciate the doctors don't have much time. So we discovered that the journal, so far I've just been doing it with a few people, and it's really working. The doctors are able to actually address some of the concerns without the patient saying it. He'll just read, and they'll be able to have a conversation. When we had a meeting with both the survivors and the doctors, each one was blaming the other party, like, no, you don't have time for us. And the doctor was saying, but you don't bring up the issue, you don't ask us. So we thought maybe this might be a way of just having this conversation, starting this conversation easily. So that's what we're working on. So far it's working. So we're trying to see if we can at least have all the survivors have a journal.
That's a really good idea. I like that. Nisi, do you want to add anything?
Well, two things I think mainly, and one from the provider aspect is that we need to understand that it starts with us. We need to be comfortable with these conversations. We need to find the right words. We need to find the right, can I say, emotional space or psychological space to be able to have this conversation. And in Kenya, we have a Swahili saying, and I'll try and translate it loosely, but it says that to talk about death is to court death. And so people will not want to have that conversation at all. And especially doctors, you have to have that stoicism and you just want to focus on the medicine and all that. And people will not want to even bridge this kind of conversations. So the moment we take the step to learn how to design, there's some classes about it. You learn how to have these conversations, then you can have the conversations. Now, the second aspect from our patient's perspective, in where we come in as the physicians, is that for the longest time, yes, and we've heard from Karen, we want to do what I call clearing and forwarding. You have a queue of 30 patients, you want to see them and move them ahead. So what I've tried to establish in my practice is I try to take time with each patient, give them time to listen, to say what they need. I always give out my number and I request them, whatever question that will come, even in the middle of the night, to put it down on WhatsApp. We use WhatsApp quite a lot, and they can always drop a text to me, and I can answer at the time that I'm available. And I always tell them, I will go through your questions and I will respond. It can get to be a lot, but at least they have that avenue to actually reach out with the question. Then the other thing is that we always, or rather, I always try to have a conversation with the patient, after which I tell them to wait outside and I have a conversation with the caregiver or the whoever's taking care of them, or if it's the partner or the caregiver, so that I get to hear what their concerns are. Because sometimes, most of the time, they're not the same thing. And so it gives me at least a wide aspect to understand what exactly this family is going through. And that has helped us to encourage these conversations, and we keep having them. Every appointment, we sort of pick up from where we left off and we continue.
Thank you. Victoria, do you want to add anything?
Well, only yes, just to say that giving the opportunity in one appointment is not the same as always giving time and building in time, because quite often people will go away, they'll come back. And part of that building trust, that bridge building between patient clinician, is the feeling able to bring it up when it becomes important, because it might not be, sex and intimacy might not be important straight after diagnosis. That is going to become important. Having a stoma, it is going to become important at some point. So giving the information, but always leaving space, or always asking open questions and actively listening, I think are really, really important. And then the only other thing I would say is, everybody's spoken to this point, but just to reinforce it from a patient perspective, the power of community is incredibly important. Sometimes people don't understand the questions that they want to ask, or even the questions that they have, or how they've been impacted, until they hear somebody else express it. And then they go, oh, yes, I feel that too. So the power of community, reducing isolation, is incredibly important in helping people build resilience. To move on past the courageous conversations, to move on past the difficult points in their diagnosis, of the difficult decisions that they're having to make. So those are the 2 points to add, really, I think.
Thank you. And I think I wanted to come back to something Nisi said. Sometimes there's a disconnect between the family or some people close to a patient, and what they want and what the patient wants. And sometimes even just being allowed to hear the voice of the patient can be quite hard if someone else is speaking for them. And just wonder how you navigate that sort of situation. Nisi, maybe you can start.
That's one of the most difficult problems that we face, especially when yeah, when, like you said, there's this disconnect between the relatives and what they want and the patient and what she wants. I try to listen to both of their sides. But at the end of the day, I try to sit with all of them, with the patient and even without the patient, and explain to them that they may love her, they might care for her, but it is her body, it is her life, and it's her choice. And she is the patient, and we have to respect her wishes regardless what they are. Sometimes they agree, sometimes they don't. Sometimes they even walk away in rage. But the most important voice that I will carry through is the patient's. And so we try and get it back to them and emphasize, especially if for partners who are maybe feeling so unattuned with what we want to do. If it's a hysterectomy, what is the fertility going to look at? We try and have these conversations through and through and still remember them. Just because she doesn't have a uterus does not make her less of a woman. And the more we talk to them, it kind of slowly, with time, they tend to understand this, and you can actually marry the two. And sometimes it just does not work, and that's okay. It can happen. The point is, your patient gets what she wants. That would be my view on that.
Absolutely, I couldn't agree more. It's encouraging them to have their voice sometimes. Karen, did you want to add anything on that?
I think she's saying it all. It's very important to listen, not just to hear them, to actually listen. And it would be easier for them to even have conversations with you when you listen and not just what's your opinion on them. Sometimes when they're wrong, I've come to learn that just to listen. So yeah.
And Runcie, do you want to add anything?
Yeah, do you mind to repeat the question?
It was just about navigating when there's a disconnect between the patient and what the people close to them, their family or their friends around them, are saying or wanting, or maybe when a woman doesn't have the chance to speak for herself, and helping them to be brave enough to say what it is they want, which might be different from the family.
Yeah, so I think that has a lot to do with really different kind of patient. There are some patients that we've seen that are very vocal and can share what they want and their aspiration. There are others that could really not be too vocal and want to just be passive. They just listen and don't want to, probably contribute because they don't want their contribution or their what they want for themselves to be seen as a barrier in the healthcare system. So I think we need to really invest more in peer mentorship and training for patients, because I think there's a lot going on around patient education, but really less around patient advocacy, especially in our own context, in empowering the patient to begin to come out, to understand that, when you come out and really speak out about your preferences, whether it is treatment holiday or is it really still going on with your treatment, that your opinion should be respected. So those are really the big issues why most of the clinicians will probably be more focused on treating the patient and treating the disease instead of treating the patient as well. So I mean, I'm not, and we've seen situations where it also comes down to where the system blames the patient for presenting late, which I usually disagree. I don't think patient just will want to present late. I think instead of blaming the patient for presenting late stages of cancer, we should really blame the healthcare system. If the healthcare system provide opportunities where screening are accessible, then patient will present early. If the healthcare system provide a system where healthcare is more affordable and where it's also available. A patient has just emailed me a few minutes ago that only for her to have immunotherapy, she's been required to pay 3 million naira. 3 million naira, it's about probably 3,000, about 3,000 US dollars. And her salary is probably less than $100 every month. And she had already finished her ovarian cancer first version of treatment with chemo. Now the cancer reoccurred and they're asking her to really do immunotherapy. Where is she going to get the money for? The system did not provide health insurance, and she is working. The insurance is not covering. The insurance is not covering her cancer treatment. So why are you blaming the patient when we all supposed to bring our voice together to blame the system and get the system fixed in a way the patient can get the right care, and not blaming any patient for late diagnosis.
Yeah, absolutely. And I think it was brought up in the chat actually about the financial toxicity, which is huge. And then, as Nisi was saying, people can be cut off from insurance. Victoria, did you have anything else you wanted to add?
I think only to say that quite often in our experience on our support lines, where there are points of friction within families, it's where caregivers, family members, friends haven't had the opportunity to understand the diagnosis, or haven't had the opportunity to also be included or involved. And that kind of typical dissonance that we see, which can be really harmful to family relationships, where the patient decides to stop active treatment and the family feel very strongly that they should keep going, they have to keep going, that they're giving up, and that can be incredibly destructive. And genuinely, I think, again, one of the things that can really help with that is community. So not just patients being introduced to patients, but partners and family members being introduced to other patients, people having conversations that are facilitated, difficult, courageous conversations, or just everyday conversations, actually reducing that isolation, giving people the opportunity to think, to ask questions, to talk to others, to reflect, and I think that very often helps to, as an emollient, it helps to kind of bring people back together again.
Oh, Dr.
I have
Glasspoint.
muted myself. Yeah, there are quite specific questions in the chat as well. There's one for Nisi about strategies in Kenya to support women in terms of fertility, like before their treatment starts, particularly for young women, possibly before their treatment commences. I don't know whether that's something you want to talk about now. I know it's quite specific to your country, but I think obviously really important.
Yeah, I can speak on it a little bit. Thank you so much, Farida, for that question. And when I speak of it, I think I speak in terms of Kenya and most of East Africa, if not Sub-Saharan Africa. When we are dealing with these young women, it mostly depends on the stage of the cancer and the type of the cancer that we're dealing with. For those who we offer fertility sparing surgery. But then we do have availability of oocyte preservation, cryopreservation, but it is ridiculously expensive. So most, if not all, women cannot afford it. And health insurance does not cover it. So the best they can hope for is probably a fertility sparing surgery and by a gynecologist, which again can be difficult because I think in the country we are about maybe 50, serving a population of about 54 million people. So I hope that answers.
Thank you. And hopefully IGCS's fellowship program is helping to address that a bit. And then Victoria, someone was asking whether people outside of the UK can access Overcome services.
Sure. So I've dropped the answer back into the chat with a link, because anybody anywhere internationally can access the online forum, and that's 24 hours a day. It's monitored 24 hours a day, all day, all night, everything, all year round. And but our services are more specifically for people in the UK, because our expertise is partly in understanding treatment options, trials, research that's ongoing in the UK, and sort of signposting patients within the UK. So we're always happy to have conversations, and we're always happy to be approached, but quite often we may be pushing you back to one of the sort of putting patients in touch with people in their own country, or where we know there are other services, like World Ovarian Cancer Coalition keep a list of other support networks and support groups. So yeah.
Well, with that, I really want to just thank all of our speakers and panelists today. It's been amazing. I want to thank all of you for joining us and for staying on, because it's been really, really great session. A huge thank you also to the IGCS team who've supported us in putting together the programme today. Just going to ask my co-chairs if they want to add anything at this point.
So I think on the behalf of all the chairs, thank you so much for attending it. And hopefully it was a very powerful, knowledge sharing by all the people who are working on the ground. So hope we were able to help you with the adding to the present knowledge and the practices that you do. And we help you to make more empowered towards boosting GYN cancer care across. As a practice, we record all the sessions. So the people who have not got time to attend it in person, probably it will be available on YouTube channel in next day or two. So you can use that, and don't forget to share it with your friends and family. So this is an important conversation. Nobody should miss it. And at the end, I think I would like to thank our IGCS Chief Energy Officer, Mary Aiken, for letting this happen and putting all the energy. And with our so much with energy, like Shreya was behind us for every task. And I think I will just praise her for sending, I think, 15, 20 mail back to back in no time. So this is the quality, and she's so coming to the database, she's so good. And I think she's communication specialist. And I think nothing is possible without communication. So this whole communication is brought to you by, powerful team led by Debbie. And I think Esle, I can see her. And apart from all the technical people who were available here, thank you so much for making this happen.
I echo what both of you have said, to thank the leadership team, and really most importantly, to thank everyone who joined us today, because it definitely is, it takes effort to be part of something like this, and it's something that hopefully you can take away and share with others, and together we continue to make an impact and a difference in all of our countries here. So again, thank you for the opportunity. It's been wonderful.
So yeah, thank you everyone so much. Thank you to our sponsors as well. And I'd just like to say how hugely privileged and kind of heartwarmed I feel to be part of this amazing global community. And it's been fantastic experience to chair the committee. I want to thank everyone for their support while I've been doing that. And I've really enjoyed today. It's been amazing. So from the bottom of our hearts, thank you.
You can stay around longer if you want.
Well, I'll definitely be around helping, but
maybe
Dr. Shankar will be in charge now,
yeah,
and he'll do a great job.
Oh yeah, absolutely.